All right, we're going to go ahead and get started. It is 7 o'clock. If any of you folks in the back row would like to fill the front seats, it would make me feel much warmer and fuzzier. Come on up if you can. All right, so we have two great talks this morning. The first one is by Dr. Kristy Hawley, Challenges and Opportunities in Robotic Surgery Education. And Dr. Hawley did her undergraduate training at USC. I learned so much by reading people's CVs, and you have definitely taken a different route. She did her medical education at George Washington University, and then did her general surgery residency at MedStar Health in Baltimore, where she rotated through several of the health systems in that area. She did her fellowship at one of the best programs in the country at Shock Trauma, and did her trauma and acute care fellowship, acute care surgery fellowship there. She started on faculty here 1 year ago. And I was perusing her CV this morning, and she did a bunch of interesting things during her education. She was a health policy fellow on Capitol Hill for Congressman Bill Cassidy of Maryland for a year. She was also a scholar at the George Washington Center for Healthcare Innovation, and that was during her training there. And then about 10 other things, which I won't get into. And I think all that training and those experiences are going to inform her in building this robotic surgery training curriculum that she is partnering with others on. She's really off to a great academic surgical career. She's already well published. She's an excellent technical surgeon and really interested in education, especially in robotic surgery. And I've had several meetings with her. Dr. Hawley, please come up and welcome.
And then just progress with the side button. Okay, great. Good morning, everybody. Thank you so much, Dr. Schulk, for the kind welcome and introduction. I just wanted to take this opportunity to talk about the challenges and opportunities in robotic surgery education. I have no financial disclosures. Robotic surgery companies do not pay me to speak, train others, or proctor. Our objectives for the talk today are going to be to explore recent national trends in the usage of robotic surgery by specialty, identify best practices for robotic surgery education from the literature, and discuss our program at CU, and summarize the challenges of teaching robotic surgery and discuss potential solutions. So a little bit of history about robotic surgery, just so we understand the context of timing around both robotic surgery and laparoscopy. So the first procedure attempted was a cholecystectomy in 1997 in Belgium. And the Da Vinci system was actually launched in 2000, and it was FDA approved for cholecystectomy and Nissen fundoplication. There have been 4 generations of the Da Vinci systems. They've done over 12 million procedures on that system worldwide through 2022. There's been over 7,500 Da Vinci systems around the world. And if you do the math, a surgeon starting a procedure every 16.8 seconds using a Da Vinci system. So it makes it really hard to ignore that this is here. This also does not take into account that there are several other commercially available systems that are being used around the world, not necessarily in the United States. So I just wanted to go through kind of where we are. And the truth of the matter is we don't have a lot of great data on robotic surgery, which makes it really difficult to inform both health policy, what hospital systems are trying to do, and then what we're going to be doing in education. So this is one of the best studies that I've been able to find. This is clinical registry data from Michigan Surgical Quality Collaborative, which is an AHRQ recognized patient safety organization. And for this study, they actually did manual extraction. A lot of the studies that you're actually seeing, if you ever review these, they're single center reports or claims-based analysis that are not as accurate. So this is one of the best ones that we have, and this came out in 2020. And then again, the data here is a little bit dated, right? It's 2012 to 2018, and as I'll show you some of these graphs, we're kind of exponentially increasing the rate at which the robotic system is being used. So I just show some of these characteristics just so that you understand that this is a very large data set here. In terms of the surgical approach for robotic surgery, it was 8%, laparoscopic was 50%, and open was 41.7%. And then on the right side, you can see the most common procedures being done in the entire data set, which is pretty expected, cholecystectomy being the greatest, and then complex cancer resections and proctectomies being the smallest. Here's a little bit more data just to understand that this is relatable, I think, to other states and even kind of our situation. So in terms of the percentage of teaching hospitals, there's 84.9% in this data set. And you can see the surgical volumes by totals, inpatient and outpatient. And then these are some really nice graphs that are showing you the proportional use of robotic, laparoscopic, and open surgery over the years from 2012 to 2018. And so you see that the use of robotic surgery for all general surgery procedures increased from 1.8% to 15.1%, which is an 8.4-fold change. And during the same period, the use of both laparoscopic and open surgery declined, which is pretty intuitive. And then in terms of trends in the use of robotic surgeries for specific procedures, and I think this is where educators might find this slide interesting, when we're looking at the overall procedures from 2012 to 2018, you see there's an 8.4-fold difference in robotic surgery use. And then in procedures that people might not always think that we're doing these robotic, we are. So inguinal hernia repair, ventral hernia repair, 41 and 44-fold difference. And then you see colectomy, reflux surgery, proctectomy, and cholecystectomy, and complex cancer resections. And then I think this is a very important graph. This is essentially saying that if your hospital buys a robotic system, that the use of robotic surgery will increase and the use of laparoscopy and open surgery will decrease. And the authors made a statement that I wanted to share. It says the study highlights a need to continually monitor the diffusion of robotic surgery to ensure that enthusiasm for a new technology does not outpace the evidence needed to use it in the most effective clinical contexts. I don't have time today to talk about evidence for all the different types of surgeries we do, but we've heard evidence throughout many of the surgical grand rounds this year. And obviously there's tons of debate here. This paper kind of took a different look. You can tell just by the slant of the title, right? The death of laparoscopy. This one's pretty decent study too. It used ACS-NSQIP data from 2012 to 2021, and it tried to predict and analyze what they think the use of robotic surgery would be for certain procedures. I'll show you a few of those graphs. But they forecasted that robotic surgery may surpass laparoscopy and open surgery in colectomies, proctectomies, pancreatectomies, and esophagectomies by 2025. And the authors conclude something a little bit different here. This anticipated change emphasizes the need for proactive adjustments in surgical training programs to align with evolving surgical practice. While skills in open and laparoscopic surgery must not be neglected, additional emphasis on robotics will be required, or surgeons and patients will be left behind. So I tend to fall kind of in the middle of both of these authors and their conclusions about what they're trying to warn us about. Yes, we know that the use of robotic surgery is increasing. Yes, we should be asking ourselves what surgeries we should be performing, but we also cannot forget that this is happening and that we need to adjust our training for the residents and fellows. So here are a couple of these graphs looking at colectomy. So the blue line here is laparoscopy, the red is robot, and the black is open. As you can see, for colectomy, they are predicting that around this time, colectomy will supersede the other modalities. Here's with pancreatectomy, again, robot is the red line. And then esophagectomy, again, red line. This is another paper that's pretty recent. This came out in 2024. This is a collaborative paper from researchers at UT Southwestern and Hopkins and University of Arizona. And these are authors who are tax surgeons, just like me, who are trying to understand what's the use in our field. Many of us trained in this during our residency, like I did. And so we're trying to figure out when is it appropriate to use it and how is it being used. So this is just an overall kind of picture, but as you can see, the graph on the left side, it's going from 2013 up to 2021. You can see cholecystectomy, colectomy, inguinal hernia repair, and ventral hernia repair. And then the one on the right is showing the robotic approach for emergency general surgery in cases from 2013 compared to 2021. And we can see that in all of those procedures, it went up. All right, so a little bit of history here. So using the laparoscopic surgery historical experience to inform robotic surgery education. And so for most of the residents in the room, you guys weren't even born, I think, when laparoscopy started. So the overall kind of challenge with introducing a new modality into, or new technology into any kind of clinical setting is that we have to ensure that patient safety is widespread during skill acquisition. A history has shown us that patient care has often suffered with the introduction of new surgical procedures. The example that's commonly cited is that there's rapid adoption of laparoscopic cholecystectomy led to a temporary rise in adverse events and especially common bile duct injuries. There are increased complications, and you'll see this in the literature referred to as the learning curve, as surgeons improve new skills through practice. And then the impact, laparoscopic learning curve issues are tied to insufficient training in CME for mastering necessary skills. So just briefly, when we think about the history of laparoscopic surgery, this was actually led by Dr. Sem in Germany at Kiel University. It's considered the birthplace of modern laparoscopy. In 1980, he performed the first laparoscopic appendectomy and faced strong resistance from the surgical community. Surgeons saw no need to replace an established method of a more complex technique. And in 1988, Sem's video, the laparoscopic appendectomy, was actually presented at a gynecologic conference in Baltimore, which inspired Drs. McKinnon and Say to perform the first laparoscopic cholecystectomy in Georgia. And this actually became the birth of these two physicians, along with Drs. Reddick and Olson, actually led the movement, I would say, in laparoscopic simulation to teach everyone, a lot of people in this room, how to perform laparoscopy. This is just a reminder to me. I came across this paper in one of my readings, and I just thought it was so interesting. So this was a picture from the first laparoscopic appendectomy performed by Sem, and then they're comparing this to the current laparoscopic standard with the use of a stapler. And what this picture reminded me sometimes is when I'm operating, right? So if I'm using an older laparoscopy set, 2D camera, not very clear compared to the robotic camera, I might see this kind of similar thing, or at least my brain is telling me that. So what was this resistance to the adoption of laparoscopy? So laparoscopy is largely ignored in the 1970s and 80s. It was seen as risky and unnecessary. There was this very traditional mindset of major issues require major solutions, such as large abdominal incisions. And I really like this quote from the British urologist, Dr. Wickham, who really was one of the people who predicted this shift to minimally invasive surgery and actually coined that term. And he said, surgeons applaud large incisions and denigrate keyhole surgery. Patients, in contrast, want the smallest wound possible. And we at Britain's first department of minimally invasive surgery are convinced that patients are right. Things start to progress. In 1988, there's the first World Congress of Surgical Endoscopy, marking a global breakthrough. And then this is the birth of surgical simulation in minimally invasive techniques. So Dr. Sem develops the pelvic trainer in 1985. There's rapid acceptance and the spread of the laparoscopic revolution, which was really triggered by demand from patients and media. There was a significant impact, especially in cholecystectomy procedures, which we discussed. And then there's this demand really revealed a training gap. And so they use this pelvic trainer. And then laparoscopic simulation was born. FLS was created in 1997 and launched in 2004. And then surprisingly to me, it wasn't really until 2019 where Gupta and Jain published their adoption of a universal culture of safety in cholecystectomy, which is an expansion of the original SAGE's recommendations. And this is something that we all teach in our operating room every day. But sometimes, it's the cart before the horse. So we adopted a technology, then we learned how to use it. We were using it on patients, and then we talked about safety concerns. So in terms of a couple papers, I just want to go through a couple of the major papers in simulation education that really kind of highlight why we believe in surgical simulation and why it's important. So this study is from 2011. It came out of Mayo Clinic, and it essentially evaluated mastery learning simulation-based curriculum for LAP, TEP, and inguinal hernia repair. They looked at 50 residents. There was 219 TEP procedures, and they were randomized to either this mastery learning, which include web-based modules and a TEP simulator until mastery, or standard practice. And then the assessment that they performed was looking at operative time, performance, outcomes adjusted for various factors. And the results showed that the mastery learning residents, half of them were mastery learning, required a median of 16 simulated repairs until they met the bar for proficiency, and that the range was 7 to 27. So you can see it took some residents up to 27 tries on a simulator until they felt that they were meeting the proficiency standard to then go to the operating room. When they were looking at operative outcomes, they found that they had, the mastery students had faster operative times, 34 minutes versus 48 minutes. They had higher performance scores using the goal score, and lower complications and overnight stays. And so the conclusion here was that the curriculum improved operative time, performance, and reduced complications and laparoscopic TEP repair. This was the first study to document clinically relevant improvements in patient outcomes after simulation-based training in the setting of procedures performed in the operating room. And it's also one of the first studies that use video recordings to assess intraoperative errors. And I think this really sets a very high standard for how we should be performing our assessments of residents, but this is extremely time intensive. The next one I wanted to touch on is a study that included 20 bariatric surgeons in Michigan statewide improvement program from 2006 to 2012. Each surgeon submitted probably their best videotape of a laparoscopic gastric bypass. There were peer ratings from a scale of 1 to 5. And there were greater than 10 blinded surgeons who looked at the videos, and they assessed the relationships between skill ratings versus risk-adjusted complication rates using data from clinical outcomes registry that was quite large, involving over 10,000 patients of all of those surgeons. And they found that technical skills rating ranged from 2.6 to 4.8 out of 5, and surgeons the bottom quartile versus the top quartile had higher complication rates in the bottom, higher mortality rates, longer operations, higher reoperations, higher readmission rates. So they concluded that there's wide variation in technical skills among bariatric surgeons, and greater skills linked to better outcomes, fewer complications, reoperations, and readmissions, and the suggestion that peer ratings may effectively assess surgeon proficiency. And in this community, the Michigan surgeons then decided to actually kind of create a collaborative where they brought the best surgeons, the highly technically skilled surgeons that may or may not have been the oldest surgeons in the room, to come and kind of mentor and get everybody up to speed, which I think was a great idea. And then finally, the last kind of historical paper I wanted to talk about is this concept of cost savings from reduced catheter-based bloodstream infections after simulation education for residents in a medical intensive care unit. And essentially, the reason I bring this study up is that a lot of these metrics that we think about, we can also tie them back to cost. So I think when we're thinking about education, we should make it value-based. And so there was an intervention done. This was at Northwestern Memorial Hospital. There were simulations, and effectively, this is one of the only studies in the literature that really looked at the true cost of both the study and the intervention. And they found that the incremental costs attributed to each of the catheter-related bloodstream infections were approximately $82,000 in 2008 dollars, and 14 additional hospital days. And the annual cost of education was approximately $112,000. And so that was accounting for surgeon time away away from, other things. And the conclusion was that the net annual savings were thus greater than 700,000, a 7-to-1 rate of return on simulation training intervention. And this is often used as a study to point to where educators and hospital administrators can get on the same page about simulation. So what's the current state of research in robotic surgery simulation? So I've really been looking at this probably for the last year and a half and reading the literature, and I've had a chance to visit a couple of these places. I was recently at UT Southwestern last week at the ACS Simulation Education Conference, which is fantastic. So UT Southwestern, UPMC, UAB in Birmingham, and Houston Methodist seem to be the leaders in the field publishing their experience with robotic surgery curriculum development over the past decade. UT Southwestern I can speak to because they presented on their curriculum over the week. And they have at least 6 papers from 2022 to the present outlining how they have established and validated their curriculum, which now includes in PGY year, there's console and bedside assist training. PGY2, they perform a pre-test, and then they do 20 virtual reality sim-now drills, which have been validated that those actually kind of translate into better outcomes in the operating room through different papers. And then they do 3 inanimate drills, and I'll show you those in a minute, but it's basically the FLS drills that were also developed at UT Southwestern, and then they perform a post-test. And then in PGY 2, 3, 4, and 5, they focus on biotissue drills. They have a video library review from faculty. So their own faculty post their cases and how they would like their anastomosis performed. And then of course there's operating room time and then specialty specific courses that different senior residents are able to participate in. And so upcoming research at these institutions is also going to start including, and they're already doing this, AI-based surgical video analysis of film surgical simulation and intraoperative performance to assess both resident and fellow performance. And the reason they need to do this is that it's extremely time intensive. So at UT Southwestern, for example, they have 2 postdocs who are in charge of all of this. It's not a surgeon who's leading all of this and watching all the residents perform all of this and going to all the trainings. So here's just the example of the SimNow VR at the top, and then on the bottom, they're doing these FLS maneuvers. They're actually doing this on the robot. I don't have time to go through these papers, but as I have really read about this, I think looking at the surgical oncology literature is extremely important as a gold standard for how biotissue robotic simulation education research should be performed. These are papers from UT Southwestern, Pitt, and then we even have our Dutch pancreatic cancer group that Dr. Besselink actually came and talked to us. And so these are all fantastic studies looking at how you actually can translate things from the simulation lab into the operating room, and they're fantastic. Just a quick update on where we are nationally so that, what's going on with the American College of Surgeons in robotics education. So the ACS Clinical Congress this year had their first ever robotic course titled Essentials of Robotic Hernia Surgery. This was led by Dr. Coker of Johns Hopkins and Dr. Soriano at UCSF. And then the ACS Simulation and Surgical Education course that I just got back from was hosted at UT Southwestern. I believe this is the second year that they're doing this, but this is the first year that they actually incorporated robotic surgery education and simulation into curriculum, which was just great. All right, so I'm going to wrap this up by just stating, I'm just going to kind of read through this. This was a paper written by a bunch of robotic surgery experts that are very concerned that there is really no national standard here. So they say a universal resident robotic surgery training pathway that maximizes proficiency and safety has not been defined by a consensus of surgical educators or by surgical societies. Literature reports of unique single institution models are widespread with more than 1,000 published since 2017, and all report single multi-institution point to the need for a universal standard for training surgeons to maximize their proficiency and safety. And essentially what they do, and the residents have all seen this, they try to outline how do you get from bronze, silver to gold for technical proficiency. I would say our program is probably at gold at this moment. We're performing greater than 20 cases at the console. We are doing low acuity segments of cases. We are graduating with almost 100% of residents getting their equivalency certificate. And this is the first year that we're requiring all residents to graduate with their equivalency certificate. And then this is where we aspire to be, and this is where everyone in this room is going to be helpful, is that for cases where we find it appropriate, we're really wanting the residents to perform greater than 50% of low to moderate acuity cases. And then if we were going to be diamond, which there are some programs that are diamond, to be doing greater than 50% of complex cases. Just briefly, we are now having the residents log into the phone app and then log in on the console. For those of you not familiar with this, it's essentially showing, we have dual consoles in all of our operating rooms. So it's showing you console 1 and console 2. And as you can see, a beginner resident might have some attending intervention. And then on the right-hand side, this advanced resident who's doing the procedure on their own completely, and the attending barely touched the console. And then this gets us tons of data here: procedure volume, case mix, consult time, instruments, and energy use for an inguinal hernia repair in this case. And then just briefly about our education program. So I started this position in January. And so would love to work with all of you in the room to kind of brainstorm new ideas. And then Dr. Bedmungo has been extremely helpful also in leading the charge on senior resident robotic mentoring and helping out with all of our simulations. Our 2024 and 2025 academic year activities have basically been, we performed a needs assessment to find kind of cracks in our training. We are starting to build a robotic curriculum. We've already completed inguinal and ventral hernia, cholecystectomy and ICG, cholangiogram and small bowel anastomosis. We'd like to expand to colectomy, bariatrics, splenectomy, surgical oncology. We have a structured virtual reality simulation training for the research residents because they have time to get through that. We've been incorporating, we're actually going to start this month, incorporating Journal Club into our educational sessions. While some people are working on the robot, others are going to be actually talking about papers that critically analyze whether or not we should be using the robot for specific procedures. And then we're increasing the number of wet and dry labs using the robotic platform. Our goal is to have at least one a month for the residents. And then to wrap up, challenges and opportunities for robotic surgery education. So fellowship programs and employers have increasing expectations for advanced robotic surgery skills for our graduating residents and fellows. It is not uncommon during an interview for you to actually sign a waiver to allow them to look at your robotic data logs. And we also know that some fellows have been asked to actually show their app so that they can see how much consult time they've gotten, how many cases, what type of cases. And as I said, in 2024, we've helped our trainees by building this electronic portfolio by having them log in for every case. It's super important, so please remind the residents. The need for increasing access to lower complexity robotic surgery cases for residents to address this learning curve. And so Denver Health now has 24/7 access for all of their surgeons. We're trying to get TACs to be doing some appropriate cases to allow them to do some more lower acuity cases. And the goal is to complete greater than 50% of those cases. New opportunities for education on updated robotic systems include force feedback, which may or may not be of benefit to learners, video recordings of cases immediately available on your phone that you can play back to your fellows or residents, and this concept of intraoperative consultations across the health system or other institutions. The limitation of most simulation programs is not having a dedicated patient cart. So that's actually the robot with the arms that's on the patient to move beyond just VR simulation. And so currently, in order to not take up time in the hospital, we're relying on the company to actually bringing the console to us so that we can use the patient cart for simulation. And either there's a lack of data on residents' performance, which I think is kind of where we are, or places like UT Southwestern where they have too much data and not enough staff to kind of help analyze and validate the curricula. And then most programs lack an ACS AEI surgical simulation fellow, which tend to guide a lot of this research, and we do not have that program. And then just to wrap up, I would welcome any participation from faculty members in all surgical specialties beyond general surgery to develop simulation curricula, didactics, and educational research. Thank you very much.
7:30, we have time for one comment or question. Dr. Ross.
So I would congratulate you. I think this is great. So I actually oversee the training center, the Center of Surgical Innovation that brings in the robot. And I would suggest to you that we should open up that training center for our residents. Intuitive has been a very hard company to work with, just historically over the years. And I would suggest to you that if we could possibly align, say, Dr. Boyd's urology program, gynecology program, some of the fellowships in robotics, to get better traction on it, to really have them bring it in, do dedicated training for the residents. Have any interest in doing some of the tests?
Yeah, absolutely. And I have actually found that they've been great to partner with personally. They are really making our university a priority. So I've been able to have a robot brought in once a month for the residents so that we don't have to come in on weekends or use operative time across the street. The problem is we have the simulator, we just don't have the robotic arm. So they can't actually go and practice beyond just virtual reality in our current state. Unless we are bringing in that robot from outside. But yes, I would love to do that. Thank you.
All right, that was a great talk. So our next speaker, I think everyone knows, Dr. Martin McCarter. His title is What's the Deal with Tumor-Infiltrating Lymphocytes, or TILs as we call them. So Dr. McCarter has spent his whole academic surgical faculty career here at the University of Colorado. He did his undergraduate training at Dartmouth College, his MD at University of Vermont, his general surgery training at Cornell. And I believe that was when we first met. I was a fellow, he was a resident, and we were operating with Murray Brennan. And Murray would promote everyone. So I became the attending, he became the fellow, right, during the operation. He then did his fellowship at Memorial Sloan Kettering Cancer Center. He really is a great example of a quadruple threat. He's won numerous honors throughout his career and has led many efforts at the national level. He is an excellent doctor, an excellent surgeon. He has 243 peer-reviewed publications. He has held numerous NIH grants and is currently a co-PI on an NIH grant with Rich Tobin. As important, he's an expert skier, which is important in Colorado, and especially with telemark equipment. So Dr. McCarter, welcome and thank you.
Thank you. Well, thank you for that very kind introduction. And I think the skiing part is definitely overrated. I thought today, I'd talk a little bit about an evolving cancer therapy that has to do with tumor-infiltrating lymphocytes, or TILs. And so I'm going to bring you guys up to speed a little bit with where this is going. These are my disclosures, the important one being that I have a confirmed immunologic bias to believe that the immune system is an effective treatment for cancers. And these are the learning objectives. And this is the outline, and I'm going to go through kind of the history of TILs, some of the technical aspects of TIL therapy. And then in red, I'm going to kind of highlight a little bit of where the University of Colorado has played a role in the development of TILs. So the history of TIL really revolves around this man. This is Steven Rosenberg. He's a surgical oncologist at the NCI. He's been the director of the surgery branch of the NCI for the last 50 years, and it's been really his passion to develop improvements in cancer therapy. And his story is really pretty remarkable. He's been responsible for developing numerous treatments for cancers, including development of IL-2, which is FDA approved for treatment of cancers. Few people know this, but he was the first person to take a human cell out of a patient, genetically modify it, and put it back into that patient. That took years of regulatory hurdles and overcoming it to show that that could be done safely, but that now has become a common thing. And we use that all the time in CAR therapy now. And that will continue to expand as well. And then finally, the third major thing is the development of TIL, and we'll talk about that today. So when he started out doing this, he observed a patient who had a spontaneous regression of tumor. And he hypothesized that that had to be related to the immune system. So he went to work on this, and at first he would take lymphocytes out of patients, try to grow them up in the lab. When IL-2 became available, could expand those rapidly and infuse them back into the patients. And he called those lymphocyte or lymphokine activated killer cells. And believe it or not, the first 60 patients he treated with this had no responses. Now, most people would have given up at that point, but he didn't. He said, well, there's something to this. I got to figure this out. He went back and he said, well, where else can we get these lymphocytes from? He went to the mouse models and collected them from tumors and worked on a whole bunch of different models and eventually figured out how to get this to work in mice. And he was able to cure mice of tumors using tumor-infiltrating lymphocytes. Now, of course, we've cured millions of mice of cancer. So next step is you got to show that that can work in humans. So he worked out all the conditions and how to do this. And eventually, in 1988, he published the first paper of 20 patients in whom he had performed this, and it resulted in a 55% response rate, which is just almost unheard of. But most people were still very skeptical of this. They thought it couldn't be reproduced outside the NCI, and that was very toxic and so forth. Anybody have any clue why this data is important? Just off the top of your head. Turns out this is the date that the FDA approved TIL therapy for the treatment of metastatic melanoma in humans. 36 years from the first publication of its being efficacious. That's just true persistence and development. I mean, a lot of things happened in that time frame to make that doable. So what are the concepts of TIL therapy? Well, first of all, we've known for many years that tumors often have a lot of lymphocytes. You can kind of see the little blue dots and the black dots there. Those are the lymphocytes within the tumor. But tumors exhibit a number of immunosuppressive mechanisms, including regulatory T cells, MDSCs, cytokines, different molecules they secrete, diamond regulation, MHC. This is kind of the area that I've been focusing on, is understanding how tumors suppress the immune response and how do we overcome that. Well, one of the observations was that, well, if you take those lymphocytes out of that tumor suppressive environment, perhaps you can grow up those that are responsive to the tumor ex vivo. So you do this using IL-2 to get rapid expansion of the T cells outside of the immunosuppressive environment. And then you reinfuse them back into the patient. And on your screen right there is a picture of a fragmented tumor in the culture dish. You expose that to IL-2, and the idea is that if you can stimulate the T cells to attack that tumor, the next picture over at the left shows a degraded tumor with a lot of lymphocytes growing in there. So those seem to be the active ones that you want to focus on. Now, when it comes to TIL therapy, this really is a numbers game. And the numbers game has to do with a bunch of different factors, but one of which is the number of mutations within the tumors. And on screen right are the tumors that have more mutations on general. And you'll see over there, it's too small for you to read, but those are the melanoma and lung cancers. Those are the ones that tend to be more responsive to immunotherapies. Screen right are the ones that tend not to have very many mutations, things like Ewing sarcoma and thyroid cancer, so less responsive to immunotherapies. Now, the reason the number of mutations is important is that that generates a number of neoantigens. These are things that the immune system potentially can recognize as being foreign. However, unfortunately, very few of the mutations result in recognizable neoantigens. And even those that are recognizable often generate a very weak immune response. So, and the other problem is that when you take the tumors out of the patients and you try and grow them in the culture dish, you actually lose a lot of the lymphocytes that were there. Some of them just don't grow at all. So there's an attrition of the number of cells available. And one other observation is that we've known that the more TILs that you can reinfuse, the better the response rates. So that's, again, a numbers thing. And then think about this. When we reinfuse these TIL cells, we reinfuse billions, up to 100 billion cells. That's a lot of cells to get a response. So the other name for this therapy is something called adoptive cell transfer or adoptive cell therapy. I think you'll be seeing a lot more about that in the future. And the concept here is that you take a tumor out of the patient, you chop it up into small fragments, you then expose those small fragments in multiple different little petri dishes to IL-2, and you stimulate those T cells to grow, and you're hoping that you get some of those plates to grow a lot of T cells that recognize the tumor. So you kind of broken up some of the immunosuppressive mechanisms. You collect those T cells that are growing rapidly, you expand them even more rapidly, and then you can either reinfuse them right back in the patient, or you can actually freeze them down, cryopreserve them, and then at some later date, infuse them back into the patient. Now, the other important factor or condition here is that you have to eliminate some of the immune cells in the patient. So they undergo a lymphodepletion to wipe out most of the immunosuppressive cells just before you're about to infuse a large volume of what you hope to be very active cells. And then after infusing them back in the patient, you give the patient IL-2 to continue to stimulate those T cells to grow when there really aren't a whole lot of other competing cells to take the space. So there are a number of advantages of using T cells. It's been referred to as the living drug. And this is really a personalized form of cancer therapy. We're using autologous cells from the patient, and you're reinfusing back into the patient. The other key thing is that it is a polyclonal drug, meaning it can identify and attack multiple elements of cancers. Most cancers have multiple different mutations and mechanisms, ways to resist therapy. Targeted therapies are a very big deal, but they only target one mechanism, one pathway, whereas this can target many different mechanisms. And in theory, you could also potentially select specific clonotypes that recognize specific antigens. So if you know what antigens you want to attack, you could actually take those TILs that recognize those antigens, expand those specific TILs, and then reinfuse them in even higher doses back to the patient. You can rapidly expand them outside of the immunosuppressive environment, and you can modify the T cells that are readministered. That's a huge area of exploration right now, and I'm going to come back to that in a moment. But I think that's also promising for the future. And then, for those that get a good response, you can find these effector cells, these tumor cells, or these T cells that recognize tumors many years later in the same patient. In the mouse models, you can re-challenge patients with tumors that have been eradicated, and they will never recur again. And the other thing is, it is in theory a one and done, one treatment. You don't need anything else after that. You don't need ongoing systemic therapy or radiation therapy. So it has a huge theoretical advantage if we can optimize it. Now, some of you might be wondering, well, what's the difference between TILs therapy and CAR T cells? Well, CAR T cells are, first of all, they're taken off by leukapheresis. So you just sit down, donate some blood. They take those T cells and then they reinsert a single chimeric antigen receptor onto that T cell. So you have to know what antigen you're going after, and it can only attack one thing at a time. And the classic here is CD19. That's what we use for leukemia. And in general, the response rates have been very good, but they're not durable. And that's because tumors mutate, right? If you had one single cell that did not have that CD19 on it, eventually that cell is going to dominate and take over. And so there's a lot of high relapse rate. And it's also associated with something called the cytokine release syndrome. You might have heard that. It's kind of the cytokine storm. They get pretty sick from that. You can also have a lot of neurologic symptoms from the therapies for reasons that we don't entirely understand yet. So one of the important things about harvesting TILs is the site selection. And so generally, we want to take about 1.5 to 4 cubic centimeters of tumor. You want to minimize or select a site that minimizes morbidity because you're about to lymphodeplete them and reinfuse them. So you don't want them to be, suffering major complications from surgery. You want to avoid necrotic or radiated tumor because that typically doesn't have very active T cells in it. You want to avoid contaminated sites like GI tract, mucosal, or ulcerated lesions. And so we typically will try to select things like subcutaneous or lymph node metastases. Lung and liver are also good sites of disease. And you can kind of see some pictures here shown up there of some of the sites that we've gone after for the TILs. Take the tumor out. Sometimes you have to chop that tumor up a little bit so it's more diffuse in the media. And then on the far screen right shows that turns out that most sites that you harvest from, you can generate active T cells. Now, there might be some fine-tuning differences. We think lymph nodes might be a little better site to harvest these cells. But in general, no matter where you take them from, you can generate an effective TIL product. Now, early on during the process here at the University of Colorado, we actually were one of the top enrollers in the country for the trials that were being run here. And we had a very good success rate in producing a productive product. And so they actually came out to watch us harvest some of these tumors and created a little educational video showing how to do that. And so I'm going to show you just a brief snippet of the educational process that people have to go through in order to do this.
Once removed from the patient, I promptly transfer tumor tissue to a sterile surface in the surgical suite for immediate prosection in the OR on a sterile back table. To To decrease the time from the surgery to media placement, the pro-section should be accomplished by the operating surgeon, while the first assistant attends to the closure of the surgical wound. Here, I'm trimming the tumor tissue to remove extraneous non-tumor, hemorrhagic, liquid, or necrotic tissue. If pathology review is desired, I remove a piece of tissue to be sent separately to pathology. I keep the tumor tissue intended for cell therapy manufacturing under sterile conditions in the OR. After trimming, the viable tumor tissue should be at least 1.5 centimeters, but less than 4 centimeters in diameter. As this piece is larger than 1 centimeter, I cut the tissue into pieces 0.5 centimeters to 1 centimeter in diameter using sterile forceps and a scalpel or scissors. Smaller pieces increase the stability of tissue by having exposure to more media. Using sterile forceps, I place the trimmed tumor pieces into the prepared transport media. After this, I secure the media bottle lid tightly and wrap with parafilm.
So I'm going to show you a little bit of the data here. This is from the US trials. The drug, by the way, is called Lymphocytes or Amtagvi. And as I mentioned, we were the highest enroller in the US for these trials. And believe it or not, this was just a cohort of phase 2 trials. It's very rare that you can get FDA approval from phase 2 trials, but there are a number of reasons why that was allowed. Important things are that all the patients had progressed on prior checkpoint inhibitors, most effective therapy we had at the time. Most of them had seen at least 3 lines or more of treatment. And then after you extract the tumor, you ship it out, and it takes about 22 days for them to prepare the product, and then it's sent back to you. And in this hugely heavily treated patients, rapidly progressing on their way to dying, we had an overall response rate of 31%, which is pretty darn remarkable, with a median overall survival of 14 months. Again, very remarkable. Most patients aren't going to live more than 6 months or so. And you can see some of the pictures here of just some really impressive tumor responses here. And at the same time that those trials were going on in the US, the Dutch and the Danish had put together a prospective randomized trial. This was a phase 3 trial, even I would say a better trial design, in which they randomized patients who had failed most of whom had failed PD-1 inhibitor, just a single agent. But then they got randomized to either the next best treatment, which is a CTLA-4 antibody, or to TIL therapy. And in this patient population, they had an even better response rate, 49% response rate. So these patients weren't as heavily treated, but they responded even more, with a complete response rate of 22%. If you get a complete response rate, you are cured. You will not recur again. Even those people that have a stable disease actually will live a long time potentially. So it showed improvements in the overall progression-free survival and overall survival. Importantly, there were no treatment-related deaths. That was one of the things that held people back here, is that the toxicity of this can be quite severe. It's taken a long time to try to figure out how to manage them, and we worked some of that out. The other interesting thing is that this trial actually did 2 important things. One, it did a quality of life analysis. And by far, if you compared patients who got TIL therapy, one and done, to those who got ongoing other systemic treatments, it's unequivocal that the patients that got the one were much happier and much better quality of life. Furthermore, they were able to show that it was actually very cost effective to do that one and done, as opposed to sequencing through a whole bunch of different treatments. So what about the future of TIL therapy? Well, I personally believe that this is just the tip of the iceberg. This is going to potentially be modifiable in many, many ways that will just continue to improve those outcomes. First question that might come up is, well, shoot, we treated patients who were just on death's door. What if you move this to frontline? If you did this as the first therapy, how might that response work? And there's some very early phase 1 data suggesting you can double the response rates by using this as first-line therapy, not beating them up with a whole bunch of other treatments beforehand. Those trials, by the way, are just getting going in this country. What if you combine them with checkpoint inhibitors, right? Checkpoint inhibitors are very effective. Maybe you can figure out a way to do both of these things together and improve the response. It also has the opportunity to enhance personalized modified TIL. And there's a ton of work going on trying to figure out what are the antigens that the TIL are responding to. Can we build a library of those? Or can we identify those TILs that are responding to specific antigens in that patient, and then just select those TILs and grow them in larger volumes and give them back? So there's a lot of things happening there. We are still working on ways to study what TIL work best. There's a lot unknown about this. Think about that. You take a failed immune response, you take it out of the patient, put it in a petri dish, and you grow up a bunch of cells. You don't know what cells you're giving back per se, but you know it works. And so we're trying to figure out what works best here. This treatment is also being developed for other solid tumors. The next in line, likely to be approved, will be lung cancer. So we were also a site for many of those trials. We've done some of the head and neck trials here, GYN cancers. Almost all cancers have, even cholangiocarcinomas, have responded to TIL therapy. Not all the time. There are a lot of barriers in solid tumors, but we're working on that. And then there's the concept of this off-the-shelf TIL. Can we develop a library of TIL therapies that have been very effective on different tumors and maybe be able to give them back to patients without having to extract the tumor from them and the delays that encompasses? One such example is actually being worked on here at the University of Colorado. This is Eduardo Davila. He's an immunologist here, and he has developed something called a mighty TIL. And the concept behind this is that he'll take the TILs out of the patients, and then he'll modify them by linking a CD8 co-receptor to MYD88. MYD88 is the activation link within the cytoplasm of the cell. If you remember your immunology, you need a co-signal. So not only do you need to recognize the antigen on surface, that's what the TILs can do, but you need a co-signal to get it to activate that T cell. And this CD8 linked to MYD88 has that potential to do that as the co-signal. And by doing that, you could enhance otherwise weak or infrequent antigen responses. You can increase responses to multiple antigens at the same time. Those T cells tend to be very polyfunctional, secreting a bunch of different active cytokines against cancers. And you can reduce the need for exogenous IL-2. One of the major toxicities of this is that we give IL-2 afterwards, and you may or may not know, but IL-2 causes a great deal of hypotension and other secondary organ failure. So you have to do it very cautiously and carefully. But in any event, Dr. Davila is developing a new TIL, which we hope to have into trials here next year. And then finally, I mentioned, there's a lot that's unknown about this. We just recently, in fact, just last week, this is a picture from last week, we had our inaugural meeting of a bunch of TIL surgeons from the US and the Netherlands, really interested in understanding how better to improve the TIL therapy, and particularly for surgeons, how do we select them, the timing of administration. And so we're forming a group to look at the real world experience. Now that this is commercially available, you can treat patients with this on product. And by the way, we just harvested our first commercial patient here last week. But there's a whole bunch of stuff we don't know now that's being rolled out across patients that weren't in those controlled groups, right? It's being used in a bunch of different patients that weren't eligible for trials. So we're trying to understand how better to optimize that. And with that, I am going to finish and open this up for questions.
Thank you, Martin. That was great. When I was a postdoc in the lab, I was told immunotherapy will be the future, and it'll stay that way. But I think they were wrong. It took 30 years or 25 years, but I think we're finally there. The other thing is the University of Colorado is actually one of the leaders in the world in this space. A couple of years ago, we built or rebuilt the Gates Center with a $200 million corpus of money. And the Cancer Center has also invested tens of millions of dollars with the campus to support people such as Dr. Davila and of course our team in surgery. So we are a hotbed of immunotherapy, and there's going to be a ton of exciting stuff that's going to come out this year and over the next couple of years from this campus. One of the things you hinted at, which I think is going to be the painful thing, is the cost of doing this per patient, right? And of course, whenever you start something, it is extremely expensive, in the order of millions of dollars per patient. And, if you look at Rosenberg's first, therapy, it was tens of millions of dollars per each patient treated. How are we going to deal with that as practitioners, health systems, universities?
Yeah, that's an excellent question, and it is real. These are expensive, technically challenging things to do. Just by way, the product is rough, a little over $500,000 just that product. By the way, that's not the hospital stay and all the rest of it. However, having said that, there are dozens of companies that are working on this right now, and as you get more players in the market, you'll probably see some of those costs come down. The Netherlands actually have been able to do this in-house. They didn't do they did it all themselves, right? And they were able to bring that cost way down to the $100,000 and $150,000 range if you do it all in-house. So I think as we move forward, we'll see some of those things come down. The other thing is that understanding some of the toxicities and, can you get away from the IL-2 or at least reduce some of that toxicity? Can you get away from some of the other lymphodepletion? Can you be more specific with these things? I think as those evolve, we'll see some of those costs come down. And as I pointed out, there's a lot to be said for a one and done treatment if we can make that work.
Yeah, and 5 years of chemotherapy and surgery and whatever else for metastatic disease is also up there in the millions of dollars. Dr. Del Chiaro.
I can do without that. First of all, Martin, thank you very much. That's amazing. And personally, I believe, I agree with Dr. Schmidt that it's been a long way. I mean, we should believe that tomorrow will be the day. I think we are there, and I think that will become more and more important for every country. I have a question that maybe doesn't have an answer, but I would like to have an opinion. As much as therapy improves, much more application use. For example, right? Especially for advanced cancer and so on. One of the problems of immunotherapy has been that pseudo progression. How can that be overcome, right? I mean, what I'm saying is that using metastatic disease, using a relapse disease is not an issue. But if you use it as a neoadjuvant, and maybe we will be there, that potentially could make the operation much more complicated or even not feasible. So how to balance, if you have a treatment and you have a complete response, this is not a problem. But if you have a partial response, it can be a problem.
So let me summarize the question for the online folks. So how do you deal with pseudo progression? And I think your picture of the guy with the melanoma showed pseudo progression, right? It actually expanded before it shrunk.
Yeah, no, that's a very good point. And you could see actually in that picture, the tumor characteristics changed a little bit, but it was the same size. It looked even blacker than before. So, determining these responses actually is quite a challenge. There are some evolving technologies and, labeling T cells and so forth to try to figure out what is a pseudo progression versus a true progression. And interestingly, one of the things in the trials here is that, as I mentioned, people that achieve stable disease for a prolonged period, the duration of response over 18 months, they actually are probably, more of those are probably cured than we know. But we just haven't figured out a good enough way to truly analyze this. And Dr. Del Chiaro brought up an interesting question about neoadjuvant therapies and how that may influence this. That is going to be a challenge. One of the things we do know is that by treating that tumor with checkpoint inhibitors before extracting it for TIL harvest, that modifies the tumor microenvironment. And that may have some implications in how effective the therapies are that we are able to extract from the TIL therapy. So a lot of things that we still need to work out.
Last question or comment. Yes, please.
I'm one of the transplant surgery fellows. I had a question about the timing and location of TILs harvest. So when you were saying that the best places to get the TILs were the skin, lymph, lung, liver, is there a better location from those four, given that the liver is more often an immunosuppressive environment if you have mets in every area? And then secondly, if you think about how tumors have heterogeneity and how they express antigens across different metastatic sites, is there a reason to extract from each of those locations, and do those patients do better if you have multiple locations of TILs?
Yeah, two very good questions. The first question about the site, as I showed you, some of the data suggests that we can generate TILs, effective TILs from any site. Some sites seem to be better than others. Interestingly enough, you highlighted the liver. A lot of people know that the liver environment actually is quite an immunosuppressive environment. And so some of the earlier studies suggested don't use the liver as the primary site for metastatic extraction. However, as time has gone on, we've learned that yes, you can actually use that site. It might be a little lower down on our list, but in fact, the first patient we put on the TIL therapy here as commercial product was a liver resection. But to your second point, In that particular patient, we actually harvested from a second site. So we've got 2 sites in one patient. And there's evolving data suggests that probably using more than 1 site as for extraction of TIL probably increases your chance of identifying or growing TILs that recognize multiple different neoantigens. It's still evolving. We're still trying to figure it out, but I think you're probably right that, more than 1 site is better than 1 site.
Okay. Great talk, great questions. Have a great week, everyone. Thank you. Well,